All right, guys. Happy Friday. For those of you who don't know me, I am Elizabeth Richards and I am the CEO of Altum Healthcare Solutions. We are here today to do a pop-up deep dive. We had planned to take a break for the summer, and then we were gifted the One Big Beautiful Bill last week, and really felt like it was something that needed to be talked about, discussed. There's a lot of confusion around different parts of it. So I'm joined today by my good friend and colleague, Donny Zamora. He's the former CEO of Invicta. Donny and I crossed paths during our days at Boulder Healthcare Solutions, where I also crossed paths with Medicaid eligibility, and Donny graciously mentored me and taught me most of what I know about Medicaid eligibility. So I'm just really excited to have this conversation with him today. I'm going to do the boring part and talk about what the bill actually says, explain a few things, and then we're going to dive into a discussion between Donny and I, mostly Donny, about what the practical impacts of these particular policies are going to be on healthcare providers, their communities, their patients. So one of the things that's, I think, the biggest misconception right now is that Congress is continuing to tout that no one is going to, the enrollment is not going to be massively affected. They're only estimating about 10% of people, 7 million, would come off of the Medicaid rolls. So a lot of the sound bites coming out of Congress, particularly with the GOP, is that, they're not messing with Medicaid enrollment, or they're not messing with Medicaid eligibility, excuse me. They are messing with enrollment. They're not messing with Medicaid eligibility, that if you're eligible for Medicaid now, you're likely, besides for a few circumstances, still going to be eligible for Medicaid. The problem is, what are you going to be eligible for? What will Medicaid look like after, if this bill passes the Senate? What will Medicaid look like, and what will that look like for our patients and our communities? So I'm going to hit some of the top things right now. You guys have probably, if you've been watching or reading anything on this, you've heard about the able-bodied man. That's the idea that Medicaid was created for people with disabilities and for pregnant women and for children, and that Medicaid was never created to cover a quote-unquote able-bodied man. And through a lot of the extension that we saw in the Affordable Care Act, the able-bodied man became covered and started having some eligibility in some states, is the allegation. We're going to talk about it later, there's very massively differing statistics on how many of these quote-unquote able-bodied men there are. However, this bill does create a federal work requirement for adult enrollees who do not have disabilities or dependents. So they will have to document at least 80 hours of work a month or other qualifying activities such as volunteering. So they do allow them to volunteer if they are not able to work, but basically they want them to document that they have 80 hours of work. And Donny and I are going to talk about later, and anyone who does this knows how that is not nearly as easy as it sounds. It suspends a 2024 CMS regulation that made it much easier for parents of disabled children to get them enrolled in CHIP, which is the Children's Health Insurance Program, part of Medicaid. CMS had released some regulations in last year in 24 that was just made it easier for those families to get their children enrolled, and this reverses that, saying that they have to go back and continue through the full process. Is requiring a redetermination every 6 months of any adults that are covered under the ACA expansion. The reason for this is that under the ACA expansion, the federal government picks up approximately 90% of the cost. And so they're saying we want these people to be rechecked every 6 months to see if they're still eligible, if we're going to be paying 90% of the cost. This is one of my favorites. It mandates cost sharing up to $35 for services provided by Medicaid enrollees. All of us that do this have joked for years about the $3 that is the current copay amount for Medicaid, and how it's almost more annoying to attempt to collect and post the $3 than it is to have the $3 just not paid. So they've now increased it to $35. no one that is not able to pay $3 is going to be able to pay $35 in this economy. So I'm not really sure what their thinking is there. It limits the retroactive reimbursements to 1 month instead of 3. So the way that Medicaid works currently is if you are retroactively applying, like you're already receiving care or have already received care, and you're retroactively applying, once it is approved, it would go back 3 months prior to the date of the application. This is most often used in long-term care, nursing home type environments where families are working to get their loved one on Medicaid. They may have had to sell some assets, things like that. And so it's basically giving them the coverage, but retroing it for 3 months. This retro now goes back to just 1 month. This is also going to be a really big deal for some inpatient hospital situations with Medicaid. You've probably heard this, that it reduces federal funding to any state that is allowing illegal immigrants to enroll in Medicaid. So it's attempting to get the illegal immigrants off the Medicaid rolls. And then it eliminates the extra Medicaid funding that basically came out of the ACA. And when Donny and I were talking about this morning, I was saying that I saw that the leading article in Modern Healthcare this morning was that basically it says something to the effect of the one big beautiful bill repeals the ACA. And this is what it's referring to. A lot of the protections that are in the ACA from the Affordable Care Act are particularly around Medicaid and funding and expansion are all being removed by this bill. The thing that I think is creating the most confusion, which is why a lot of people are not adequately understanding what I believe is a complete gutting of the Medicaid system and the things that the eligibility, what you're eligible for. So there's a provider tax that states use. So Medicaid is funded by the federal government and by the state. The amount of money that the federal government gives Medicaid is calculated annually. It's called the Federal Medical Assistance Percentage, and it's a measure of the state's wealth relative to the national average, and that comes up with a percentage. Statutorily, 50% is the minimum, and then 83% is the maximum that has been paid. And so that's how the federal government decides how much they're going to match the state funds. There's no cap on that though. And so the law does allow the states to raise revenue for Medicaid by issuing taxes. And so most states, actually every state but Alaska, has created provider taxes by which they tax the providers either based on percentage of revenue or a flat fee per bed, but they tax the providers to then basically collect the funds to pay for Medicaid. So that means they don't have to reduce any other funding from any other part of the state budget. They get them from this tax, and then the government, it matches whatever that tax rate is. And so this is where, if you've seen anything in the news recently, a lot of people have talked about money laundering. This is what they're talking about, that they believe that it's a money laundering scheme that the providers are using just to get more money from the federal government. So the bill says that it is going to significantly restrict what's already in place and not allow any additional provider taxes to be created. So basically what that is going to mean is the only place that the hospitals or providers or the only place the state will be able to get money to pay for Medicaid is going to be through other parts of their budget or taxing their recipients, their state members of the state and their state tax. So that's a massive change. Also, because they probably will not be able to collect as much money or come up with as much money, they will not be getting as much of a federal match. So they're getting kind of hit twice with that. So that's the 10,000 level. What is being proposed. I think a lot of those things, most of those things you've probably heard. Some of them I may have not thought through what that means. And that's what Donny and I are going to talk about. It looks like, this policy is going to destabilize the state federal Medicaid partnership like we've never seen before. And I just wanted to know, what are your initial thoughts or responses as somebody who has spent a good portion of your career working in Medicaid eligibility?
Well, good morning. First and foremost, thanks for having me and giving me a
Yeah.
reason to actually put on business attire. It's been a minute, so thanks. My initial response, my initial reaction is I'm really petrified because a lot of people are going to suffer real and perhaps life-altering harm because of the proposed changes or the changes. For the past 50 years, there's always been incremental increases in the availability of assistance to those who are in most need. And this is something we've never seen before. So, how is this going to impact, the states, the providers, and the patients, and how they're going to respond? That's Yeah, it's going to impact a lot of change for all of the aforementioned. As it pertains to the patients. I mean, you're talking about benefits going away, such as LTSS, which is in essence long-term support services for seniors and disabled individuals. You're talking with regard to there's 13 million children that are on chip who have special needs. What happens to the special care, the special care that those children need? And so, all of this is just going to face substantial barriers to accessing specialized services. And then, that also goes into, behavioral health emergency services, including like mobile crisis units. So, all of these cuts just when you take, no pun intended, the deeper dive into who's impacted. I mean, you're looking at these critical services on the behavioral health side. I mean, they prevent suicide attempts, they prevent violent acts. There is just going to be the fallout is just unfortunately going to be widespread.
Yeah, I think you and I discussed that. I read there was another Modern Healthcare article about Uber and Lyft and how they provide a majority of the non-emergency transport for Medicaid, and they're redoing their end of the year projections, expecting to lose a large amount of that service. But it doesn't, the patients are still sick. They still need to get somewhere to be seen. Taking away their ability to get there is not necessarily going to be, best case outcome. I think one of the more concerning part is this is going to move a lot of this back to the local level. Individual, state governments are going to have to decide what they cut and what they don't cut. I think that there's been a lot of conversation about how drastically that could differ between different areas of the country, or different political leanings of the country. When it comes down to deciding, we've lost all of these funds, are we going to cut and what are we going to cut? Is really a scary proposition when you think about it, particularly with the things that you're talking about, like the children, the special needs children, right? Like, that are receiving services. I actually have a friend with a special needs child, and she's extremely concerned about it, and extremely concerned about, am I going to have to move to a different state that has better coverages? So I think it's really scary. I think that community in particular, I've heard, is really nervous.
Well, yeah, I mean, I think what we can count on is that there's going to be fewer staff. There's going to be budget cuts. It's going to impact the number of people hospitals can employ.
Yeah.
So there's going to be fewer staff to handle more uncompensated care. And there's also going to be an increase in emergency department delays, and more people are going to continue to use the emergency department as their family practitioner. Because when you get down to like the barriers to enrollment or re-enrollment, a lot of patients, the psyche of the Medicaid patient doesn't really change regardless of what the legislation says. They, the psyche of the Medicaid patient will forever be, they're not going to think about re-enrolling in Medicaid until they're actually presented with, they feel sick and they have to go get care. So unfortunately, hospitals, emergency departments specifically, will continue to be the primary point of re-enrollment. So asking the patients to, we're going to get to work credits here in just a minute, but there's going to be there the barriers enrollment are going to increase, and the cuts to funding are going to, especially on the rural side, may lead to some closures. It'll also lead to fewer doctors accepting Medicaid. So in essence, it's really gonna create what I call like deserts for this uninsured population.
Well, yeah, I mean, I think anybody, like you said, the psyche of the Medicaid patient. I mean, the average Medicaid patient, is lower educated. They usually have 3 to 5 chronic conditions, I think was the last statistic that I heard. Their recidivism rate, as far as how much time they come in and out of the hospital, is extreme. They are lower income, so they're not getting good nutrition, they're not getting good support services. So these people are going to continue to get sick. And if you take away the small amount of services that they're already receiving, then they're going to just get sicker. And it's just, like you said, a complete downhill effect about how that affects the hospital's ability to stay open. But also, I always tell people about healthcare is like, and my feelings on Medicaid changed dramatically after I worked in Medicaid eligibility, because the reality is these people are still coming to the hospital. So we either pay for them through Medicaid, or we pay for them through increased costs to other patients, or we pay through them through taxes through the state or the federal government. But you can't keep the people from coming to the hospital. So the idea that you're just going to cut out all of this in your one big beautiful bill, and then the patients are just going to go away, is just so unrealistic.
Yeah, and I think unfortunately, it's the hospitals and the patients that are going to suffer the most, especially with regard to public health concerns. When you read the fine print about what's going away, in essence, everything that would, in essence, vaccinations are going away, child checkups are going away. So there's going to be a rise in preventable hospitalizations and episodes of care in the ER. And then there's also going to be a decrease in childhood vaccination rates. So when you're taking away all of these support services that are aimed to prevent, a big long episode of care that's going to end up in a 3 to 4 day hospital stay, they're just the uninsured population is just there. Those preventable things are just going by the wayside. So it's
Yeah,
going to
it's really
create
scary.
it's going to create a lot of hardship for a community that's already underserved and really taxed.
So shifting gears into a not more positive subject, but let's talk a little bit about the Medicaid work requirements. Arkansas and Georgia have already tried this with little success. Do you have any comments about your experience with, what you've seen with that, or thoughts on the work requirements?
Well, this is we're in unprecedented times. This is the first time in Medicaid's 60-year history that recipients between the ages of 19 and 64 would be required to work at least 80 hours a month to retain their benefits. So, it's they are it's going to create a lot of additional red tape, because you're asking the states who never before had to keep up with their work credits are going to have to come up with a system in which to track to track the community service hours of their enrollees or their work credits. And so the system is already taxed. If you look at with regard to Social Security Administration offices, DHS and DSS offices, their caseloads are bigger than they've ever been, especially on the TANF side or the food stamp side. People expected the food stamp utilization to go down after the pandemic, but it's still at or above pandemic levels. So the processing of applications for food stamps, and then for age blind and disabled applicants, and then to take it a step further and to ask those who are eligible to also have to submit their community work hours and their community volunteer hours or the work hours. I mean, it's a pretty daunting task, because let's face it, it's hard enough for these people to show up the verifications that they need in order to get qualified initially for Medicaid, right? It's hard for them to get a pay stub, get a domicile information, show some dependents, get birth certificates, get social security cards. Oftentimes it's just one and done. You're lucky to get that. But that they ask them to go out and get yet another verification, but also to find the time in which to do this and find the agencies that are allow them to do that, to be like, hey, I'm a Medicaid recipient. I can only work X amount of hours, or can I volunteer for these hours? So it's a pretty high hurdle.
Yeah, I hadn't actually thought about, I have for years thought about, I know when we were, when I was were running Medicaid eligibility for Boulder, they were looking at this in a couple states, and we were kind of trying to stay in front of it and decide, how or what we would be able to do to assist the providers. I hadn't thought about the fact that from the state system, you're asking them to come up with a whole new verification system with less money than they have today in an already taxed system. Another common comment that I heard, how is this going to work? So if I lose my job, then I lose Medicaid for that month. How is that gonna be handled? And I grew up, my former boss and mentor told me stories for days of driving to pick up Medicaid patients to then go through their house and look for their documents to then take them to the Medicaid office. We don't do that nearly as much anymore, or probably not at all anymore, for safety reasons. But like for years, that's why Medicaid eligibility companies went door to door, is you cannot get these people to call you back or show up at an office or provide you the forms that you need. And so just asking them to have to provide another significant form is just another level of I was going to say bullshit, but Angela's going to make me cut that out when she edits this. That's a legal term, bullshit. So I also think that when we had talked about this before, when some of just the individual states were looking at it, some of the providers that I was working with were talking about creating their own. Most providers have community service hours. So they were talking about, well, if we can identify these people, should we just go ahead and offer them community? Like, should we take on giving them the community service hours in order to make sure they stay eligible, knowing that they're our patient and they're costing us all this kind of money? So I think hospitals and providers are going to have to be kind of really creative about that. Is like, hey, okay, maybe we can't hire all these people, but we can probably give them the community service hours that they need. Of course, then you have to get them to show up. And you're talking about a group of people that can't pay their bill. So they don't care if they roll off Medicaid and then they owe the hospital $20,000. They're never going to pay that bill, and they're not collectible. So that's my other thing, is like, how are you going to get these people to actually show up to do 80 hours of community service or work if they don't really, like, what do they care? Because they're still going to be able to go to the hospital, and they're still going to be able to go to get, and also when you combine that with how we're talking about how what they're eligible for is going to be gutted, it's like, now I don't get this service, this service, this service, and this service that I was getting, but you want me to work 80 hours a week, or you want me to do community service for 80 hours a week. Well, I don't care. I don't care if I have Medicaid. What does it matter to me?
Providers going to be at a crossroads, because, in the past, right now, a provider, if they wanted to be really proactive, they could run a report of all of the Medicaid recipients that they provided service to last year, and they could run a report, and they could have they could find out when they were falling off the rolls, and to call them and say, hey, Mr. Smith, Smith, your coverage is going to lapse. Can we help you re-enroll? Now you have to take it a step further and say, now they have to run that same report, and then they have to figure out what type of coverage this patient actually has, to see if they have to abide by the work credit or the community service now.
Right, or the re-enrollment, because they're part of the ACA expansion, so now they have to be re-enrolled every 6 months. So that's another part of it that you're going to have to flag, because as we've said, these patients aren't going to go out and re-enroll themselves. And that was kind of, flips into my next question, is with all of these changes to eligibility enrollment, I think we've hit on a lot of this, more frequent enrollment, citizenship checks, work requirements, more requirements for CHIP. It seems like a lot of people are going to lose their coverage just because they can't navigate the system. I mean, it's hard enough for people that do it for a living, the patient advocates that used to work for me, to navigate the system to help these people get on Medicaid. But if you are just trying to get yourself on Medicaid outside of the hospital's assistance, I don't know how you ever figure it out.
Yeah, you're right. And it's just a matter of, what kind of communication efforts are the states going to put out? Because the way in which the literature is written now, it's going to be completely dependent upon the states to make sure that their Medicaid recipients are aware of the upcoming changes. And how are they going to reach out? Are they going to reach out to them by phone? They're going to reach out to them by text? Are they going to run ads? How are they going to broadcast these sweeping changes to the criteria for enrollment to the masses? And because we all know, those of us who've worked in the advocacy space, we know that sending a letter these days, I mean, yeah, that's a waste of a stamp, because they're not going to check their mail. So, it's going to take a kind of an all hands on deck approach from the state level to be able to connect and really kind of drive home the idea, well, the criteria, the need that in order to keep your benefits, we're going to need you to work, or please call us so we can explain to you the changes. So they're going to have to create a checklist or a how-to list, or they're going to have to get pretty creative in trying to communicate these changes to their different communities.
Well, and again, with less resources than they've ever had before. It, yeah, I mean, it, it is apparent. I don't want to make this a political conversation, but it would appear that a lot of this is intended to get people off the rolls. It's intended to make it harder for people to get enrolled. And again, that doesn't solve the problem that those people still need healthcare, and they're still some of the sickest members of our society. So yeah, it's going to be really interesting to watch, and the fluctuation and even and in just the fluctuation in the patients that are and aren't enrolled. And like Donny and I could probably talk about this all day, because now my brain is going to, but now our 30B credits are, at issue, which is another tax they can get from the government for having a certain number of Medicaid patients. So now that you aren't able to maybe meet those requirements because too many of your people have fallen off Medicaid. I mean, like you said, this is really like a tornado effect across the entire hospital provider system. All right, so last question for both of us, actually. What are some things that you think that providers will need to prepare? I know we've already mentioned some of them, for the potential financial impacts, as well as serving a potentially larger self-pay population. What other practical measures from your experience do you think is going to be helpful in ushering people through the next couple years? Because it's going to take a couple years. That's the other thing that I'm reading, is as these provider taxes credits run out and are not able to be renewed, if this bill passes, it will be a couple years before we fully see the complete effect of this.
Yeah, I think it starts with across the board. I think it starts with open lines of communication and more town hall meetings, not only within the four walls of a hospital, but also in the communities, because there's just as much education is going to have to take place for hospital employees as it is for the underserved communities. So I think it's going to take a lot of public and private partnerships. They're going to have to, I think hospitals are going to have to increase um, their their telehealth initiatives, but also their advertising. They're going to have to spend more on their advertising dollars to make folks aware of what's going on within their communities. So I think it's an integration of services, and then trying to coordinate with your nonprofit, a lot of the nonprofit community resources. But then again, I mean, I am the byproduct of, I grew up on the southernmost tip of Texas, in and around a lot of poverty. And, I think some of the people that help those people the most are the social workers and the case managers and people that work in enrollment and health advocacy. And I think those people are going to, I think providers need to watch out for fatigue, because social workers and case management, they're already taxed. They're always looking for ways in which to help their patients, rightfully so, right? They have masters in social work, or they just have the need to help people. Well, all of the resources that Medicaid typically provides for a lot of those people they're going away. So I think it's important to really make sure that our provider people out there just realize how big of an impact this is going to have on the frontline people, fortify the front lines, and make sure that those people also have the mechanisms in place to help them kind of, you know, navigate the new reality of Medicaid.
Right. Yeah, that's actually that might be the follow-up conversation we have. You might have just titled it The New Reality of Medicaid, because I think that that very much is what we're looking at. You know, even if the bill doesn't pass in this very specific format, it's going to pass in some format that is going to dramatically affect Medicaid. And that's why the sound bites that are coming out of Congress about, oh, this isn't going to affect people that much is just really, really short-sighted and non-educated. And there, like you said, there's going to be a lot of social shuffling. Like I think about, you know, social determinants of health are always like a really big conversation. You talked about food and care deserts, what that does, you know, and I think we've never looked at if we add to the social determinants of health this new Medicaid coverage. So now there's not even the vaccines and things like that you mentioned. They're not even getting even what they're barely getting now, and already in a very high risk population. They're going to be an even higher risk population, an even sicker population, and we're going to be trying to treat them on less money. And I just don't see how that ends, you know, anywhere positive. But I agree with you. Town halls, being creative in your own facility about how you approach the issue, getting with a good partner that's specializing in this. I mean, those are really the only things I think at this point. But also like not sticking your head in the sand like an ostrich. Like this is coming and it's coming hard. And hospital boards need to be talking about this. It needs to be talked about when it comes to projections for revenue, like needs to be talked about when it comes to capital finance planning. Like it's coming. So it's not something that we can, you know, sit and ignore and hope that it goes well. Well, Donny, this has been so much fun, not just because it's you and I love talking to you, but I love your perspective and your and your just your view on Medicaid has always been so inspiring to me. You know so much about it and you have such a passion about it, and it's always great to get to talk to you about it. And I really appreciate you agreeing to join me on this pop-up today. And it sounds like we might be doing a follow-up entitled The New Reality of Medicaid.
I'd love that. Thanks again for having me.
Of course. Awesome. Y'all have a great weekend. Thanks for joining.
Thanks, everyone. Take care.